Hello, class. This is Dr. Mike Burford coming to you today to talk about psychopathology. More specifically, I want to talk about disruptive impulse control and conduct disorders. I want to remind you that information from this presentation comes from the DSM-5, which is, once again, I'll tell you, which is your go-to guide when you're in practice in terms of diagnostics. Okay, so let me give you a little overview of these type of behavioral disorders. There are problems with self-control and regulation of emotions and behaviors, conflict with societal norms, rules, laws, and authority. Etiology for these types of disorders, various behavioral disorders, may vary. And they are more commonly seen in males, and onset commonly occurs in childhood or adolescence. And so when I think of behavioral disorders, I usually think of children or adolescents. And in fact, I spent many years working with this particular population in congregate care settings, group homes, things of that nature. And so I have lots of experience with these types of disorders. The DSM-5 indicates that it is possible for adults to have some of these disorders. But again, I think of children and adolescents when I think of these disorders. And I want to go back to the first 2 points when I said something about problems with self-control and regulation of emotions and behaviors. I think that's probably true with the disorders that I'll present today. Conflict with societal norms, rules, laws, and authorities. I think that'll vary depending on the disorder. And again, like in my other presentations, I want to remind you that I'm giving you the disorders that I commonly see or have seen in a clinical setting, and ones that I strongly suspect that you will see too if you go into private practice or clinical practice of some kind, not necessarily private practice. All right, so let's talk about a behavioral disorder as a concept for a moment. Behavioral disorder versus developmental angst, autonomy, and boundary testing is an issue. When we think of adolescents especially, and kids too sometimes for that matter, but especially adolescents, we think of a developmental period and process where the kids are trying to test boundaries and see where they stand in terms of pecking order. And as adolescents, it's a time of growth, and it's moving from being a child towards being an adult. Bowlby's attachment theory will provide lots of light on that for you if you care to read Bowlby and his attachment theory. And basically what Bowlby was saying, and I believe to be true, it makes good sense, and of course things that make good sense aren't always true, but from a rational perspective, I believe that Bowlby has hit the nail on the head, and in fact Bowlby and his theory, attachment theory, has guided my practice on many occasions working with these adolescents. So basically what we have with adolescents is, in accord to Bowlby's attachment theory, is that, again, adolescents are in the developmental process of moving from childhood into adulthood. And so what that means is that they push boundaries, that they are attempting and practicing being an adult, at least to some degree. And some of them, of course, do better with that than others. But almost all of them want to disengage from the way of being as a child and the relationships with their parents as a child. And so they're seeking autonomy, and they're trying to interact more with their social environment. They're trying to move away from the parents and more towards peers, and that's why we often, in adolescence, have complaints in a clinical setting from parents that the adolescent doesn't seem interested, doesn't seem engaged in the family, is more interested in hanging out with friends, is unruly to some degree, pushes limits and boundaries and so forth. The interesting thing with those kids is that adolescents is that they tend to like to have parents there as a safety net. So even though they're moving away from parents and they're practicing being in the social world and becoming their own unique, autonomous individual, they do find comfort in knowing that mom and dad, or ever who it is, it's care provider, that they're still there and that they serve as a safety net. And also remember that kids do, even though sometimes they don't act like it, they do need to be provided with structure, and they need to know that someone is in control, and that provides safety for them. So back to the issue at hand, sometimes it's a bit difficult to know the difference between a natural developmental process in adolescence, for instance, as opposed to a disorder, a true behavioral disorder. And so oftentimes the difference is clear in terms of frequency and duration of the problem, and intensity as well. In the cases that I've seen in clinic, it was quite obvious that the adolescents were struggling with way more than just the normal developmental period that all adolescents tend to go through. The other thing I can say about it is that parents have often brought their kids into me to be fixed, and they'll plop Junior or Sissy down in front of me, and they'll proclaim something along the lines of, "I have brought my kid to you so you can do something with them, so you can fix them." And oftentimes what I'll say to the parent is that, well, okay, I understand that your child or your adolescent has some behavioral problems, but more than likely we're also going to need to look at some parenting styles and your role in things and how you're doing or not doing things. And some parents are okay with that, and then some of them look at me like I've lost my mind that I would ask them to participate in therapy, and that indeed they are most likely, not always, but most likely part of the problem, and need to make some adjustments in their parenting style. Okay, so let's talk about some of the disorders now. One of the most common disorders that I see in adolescents is oppositional defiant disorder, and it's basically how it sounds. There's a pattern of irritable, angry mood that's often present. They're often argumentative and defiant, and often vindictive. I'm thinking of several cases, most of the cases actually, that I have had with adolescents with ODD, and they were markedly angry and agitated towards their caregiver, their primary caregiver, whether it be a parent or a grandparent or what have you, to the point that they would intentionally start arguments and just be very nasty in general verbally to that person. The intensity of their anger and defiance far outweighs anything you would see in a normal adolescent developmental behavior. To be around these types of kids, one immediately recognizes that something's very much amiss and wrong. All right, so for this disorder, this pattern of behavior from the adolescent or child needs to be greater than 6 months, so a duration greater than 6 months. And they commonly disrespect authority across spheres. And oftentimes they can be nice for a while if they choose to, but it's usually a very shallow, short-lived effort at being pleasant. The minute that they feel that their toes are stepped upon, then they become angry and argumentative and defiant. Most often that's the case anyway. And it's common to see these types of kids have problems at home and at school, in social settings. Sometimes police may be involved in terms of family disputes and that kind of thing. Or maybe the school safety officer or something along those lines. It's certainly not uncommon for these types of students or these types of clients to be very disruptive and disrespectful at school and social settings and that kind of thing. I'll give you two really quick examples. I remember from my cases years ago, I remember one particular fellow that had oppositional defiant disorder, and he was having a tantrum, and there was an administrator that for the agency where I worked, and she happened to be coming through a building, and the windows had just been replaced in the building, and she immediately got involved with the kid's tantrum, which was a mistake. She did not have a relationship of any kind with this particular boy, teenage boy. So naturally he didn't know or respect her at all. She hadn't invested time in him. And so she escalated him, and his behavior got worse to the point he picked up a chair and was telling her, if you don't go away and leave me to work with staff, I will throw this window through the new chair, throw this chair through this new window. Well, apparently she didn't believe him, and so he chucked the chair through the new window, and it was one of those real big windows too. So I guess he made a believer of her. I'm also thinking, and this was in a group home, but I'm also thinking of a school environment. I had a young fellow who had oppositional defiant disorder and decided that he was unhappy in math class one day, and so he was quite defiant of the teacher and wouldn't listen, wouldn't stay in his seat, wouldn't stop pestering other students. The teacher became more and more agitated with him, and of course his response became more and more animated, and so he ended up getting under his desk, crawling up and under his desk on all fours, barking like a dog, and refused to come out, and stayed there for a good 30-45 minutes or so. Of course, we addressed that in therapy. I thought it was rather humorous. It was sad in a lot of ways. He was missing out on his education, but it's one of the more colorful things that I've seen some of the students do in a classroom setting. And again, the last point I wanted to tell you real quickly that there are three different subtypes or three different specifiers for ODD, and that's mild, moderate, and severe. For the mild specifier, the symptoms occur only in one setting. For the moderate, it'll be present in about 2 settings. And then for severe, it'll be present in 3 or more settings. And these people commonly defy rules, sometimes for no other reason than to be defiant. Sometimes it doesn't make sense at all why they're doing the things that they're doing. Okay, so now let's talk about conduct disorder for just a minute. Now, in the DSM, the old DSM, there were 3 main types of behavioral disorders that I would see a lot, and conduct disorder would be the most severe, followed by ODD, and then something, I believe it was behavioral disorder not otherwise specified, and that was for behavior that didn't meet criteria for ODD or conduct disorder, but yet was still more problematic than what could normally be expected and was disruptive to the person's life. Okay, so conduct disorder. So there's a pattern of violating rights of others with conduct disorder, or violation of major societal norms, rules, and laws. And these people may lack remorse and empathy and not be concerned about performance in school or at the job or any other place where demands are put upon them or expectations are put upon them. And they may not express sincere feelings at all. And this disorder requires the presence of at least 3 of the 15 DSM-5 criteria for conduct disorder within the last year, with at least 1 criteria being met within the last 6 months. And common criteria include aggression to people, such as assaults, rape, those kinds of things. And then it includes destruction of property, deceitfulness and theft, and serious violation of rules. And when I see somebody with conduct disorder, their behavior usually is the type of behavior that if they were 18 or older, they would be arrested and put in jail for the behavior that they routinely engage in. Now, there are subtypes of conduct disorder. There's childhood onset type, and that's for onset prior to age 10 years. There's also adolescent onset type, and then there's unspecified onset type. Now, what I can tell you about childhood onset type is that kids who have conduct disorder at such a young age are more likely to carry that behavioral disorder throughout their teen years, and then as an adults are much more likely to develop antisocial personality disorder. Adolescents, on the other hand, with conduct disorder that have recently developed the disorder are much more likely to eventually change their behavior and improve and function a lot more appropriately. And of course, there's various specifiers. Mild, moderate, and severe specifiers are there. I can tell you just real quickly about a case. Over the years, I've had several kids with conduct disorder. I've had kids that have committed armed burglary and armed robbery and have been shot and yet turn around and do it again. One of which I recall is in the state penitentiary right now. And despite the conversations we had about doing the right things and making appropriate choices and all that, I mean, that went in one ear and out the other, apparently. But so he ended up running away and robbed another place and got caught and was in the penitentiary. I've had kids that committed armed robbery at restaurants and have kids that have stolen vehicles, sometimes from the group home. You know, it's quite a feeling when you look out the window and you see the company van going down the road, and you know that it's not any of the staff because they're elsewhere doing other things. And you know, as a therapist, sometimes I remember once I saw somebody stealing a van. The staff wasn't supervising the person and had been neglectful enough to leave the keys where they were able to be accessed. But anyway, so I'll tell you one story that I found to be interesting. We had a boy that ran away and went down to the University of Tennessee area went down on campus, and he and another guy tried to mug a female student. Well, it turns out she was a soccer player and pretty good shape, in pretty good shape as an athlete, and she ended up beating him up. So here's this big old teenage boy that was quite large in size, and she put the whip on him and all that. And I don't condone violence, but I found that was an interesting little story there. But I've got a bunch of those I could tell you about if I ever meet with you in person and you wanted to know more about those kind of things. Stories that I could tell you about some of the interesting things that happened. Now, let's talk for a minute about intermittent explosive disorder. In my career, I've seen, a handful of kids, not a whole lot, but I have seen a few with this particular disorder. This disorder entails recurrent behavioral outbursts and failure to control impulses. They're usually verbally aggressive when they have these outbursts. Physical aggression can occur. Usually there's no physical damage or injury. And the incident occurs at least twice weekly for a 3-month period, or 3 outbursts within a 12-month period that involves physical injury or destruction of property. The magnitude of the outburst is out of proportion to the precipitator. It's not premeditated, and the person is at least 6 years of age. I can tell you that when you have somebody with this particular disorder and they're having an outburst, if you don't realize that they have this disorder, it'll leave you sitting back scratching your head thinking, well, why in the world did this person get upset and what was all that about? Obviously, the idea is if you can identify what the problem is, perhaps it can be addressed and avoided in the future. But it can certainly leave you scratching your head wondering what it was all about. I want to talk a little now about pyromania, and that, as you may know, is a pattern of deliberate fire setting. People with pyromania have a feeling of excitement prior to fire setting and a satisfaction when the fire setting has been completed, or when they participate in the aftermath of the fire. Fire setting is not done for financial gain, to cover a crime, or as an act of vengeance in order for it to qualify as pyromania. And over the years, I've had, I can think of about 3 or 4, probably no more than 5 clients that had pyromania. And the interesting thing about them is I can think of 2 of them that had been convicted of committing the crime. And they tended to not be bashful at all about what they had done, and actually appeared to enjoy remembering the experience and telling me about it. And they reported feeling excited and having a feeling of being empowered and having control, and of having a level of defiance. That's the report that they gave me about it. And of course, the person that I remember that had been accused of fire setting hadn't been convicted yet, wasn't saying a whole lot about it for obvious reasons. But I can remember 2 clients that I had that burned a home to the ground in each case. Burned it to the ground. One of them was a foster home. Okay. I want to talk just real briefly here about treatment for these types of disorders. Now, a therapeutic relationship with these adolescents and kids helps a lot. If you can develop a therapeutic relationship, if you listen and allow clients to feel heard, it's very important, even if you disagree with them. Now, for instance, I would have a kid come into me with one of these disorders, and they would be in a funk. They would be, that's not a clinical term, by the way, a funk, but you know what I mean. But they would come in and say things like, I'm frustrated and I'm about to explode or tear this place up, or whatever they would say. And I would say, well, why is that? Come on in, have a seat. And I would make time to see them. When they knocked on my office door, and which was in the facility, and I would listen to them for, I don't know, it usually took about 10 or 15 minutes, and they would blow out all these frustrations and threats and all these other kind of things. And oftentimes they would be yelling, and then I would say, well, hey, I'm not yelling and don't understand why you're yelling, and if you'd like to continue to talk with me, you need to lower your voice. I'm glad to hear what you have to say, but I can't do that when you're yelling. And so I would get them to lower their voice, and after about 15 minutes, they would be fairly calm, and we would be able to problem solve, and I would be able to gently challenge and help them reconstruct or reframe their point of view. But in the beginning, if I were to say, oh, no, you're wrong, then that was just going to escalate the situation further. First, I let them know that I was willing to listen. So, especially when I was working in a group home, there was a little saying that I had, and some of the other staff members had, and it went along the lines of "pay me now or pay me later," and that's what we knew that we would have to do for the kids. That either way, they were going to get our attention. The question is, how's that going to play out? Now, I had staff members that would come in, and they would be fairly new, or they would be pulled from one of the other group homes, and they would come in and they would try to bark orders to the kids and be pretty stern and come down on them pretty hard. And of course, the kids would have none of it, or very little of it. A lot of them wouldn't anyway. And would end up in my office and that kind of thing. But the problem there is that person didn't have a relationship with that kid, and they hadn't invested time with that kid, and that kid didn't know them and didn't trust them, didn't think that they were on his or her side, or at least willing to hear his or her side. And so the idea was, and what I tried to teach staff, is that you'll pay attention to these kids sooner or later. So the best way to do it is do it correctly. And so, for example, when I would go into work, as I made my way to my office, I would usually have 2 or 3 kids that would stop me along the way, and they would want to ask me how my day was, or tell me something they had done, or engage in me in some way. So, and so I would stop, and I would talk with one of them for about 5 minutes, or ask them how they're doing, and was really concerned, was really wanting to know, and all that. And so I built a relationship with these kids. And in the group home, there were usually kids that were as big or bigger than I am. I'm 6 feet tall. Some of them were taller than me, weighed more than me, and had a criminal record of aggression and violence and all of that. And so some of these kids were fairly scary kids in some ways. But even with that, because I had invested in those kids, and because they liked me for that reason, I could ask just about any one of them to stand on their head and bark like a dog if I wanted to, and they'd probably do it. And that's the example I used for staff. These kids, if you develop a relationship with them, a therapeutic relationship, will work with you, are a lot less likely to hit you. are a lot less likely to stop fighting if you jump in the middle of a fight, which if you work in the group home, sooner or later you'll have to do. If you want them to start fighting, that is. So anyways, it's a real simple concept. You'll either spend time with that, investing in that kid before there's a problem, so that when there is a problem, you can handle it much more smoothly and efficiently. Or you have the option of waiting until there's a problem, and then good luck to you. It could get pretty ugly. When you're working with these types of kids, you want to identify common goals. I remember many a time I would have a kid that would be going on and very angry and upset, and sometimes rightfully so, about something staff had done, and I would try to address that with staff as necessary, but in private, of course. But sometimes the kid would be almost inconsolable. And so what I do at that point is I say, well, what do you want? And I knew that the answer was usually going to be, well, I want to go home, or I want to go to be with Aunt Judy, or I want to go be with somebody that, get out of congregate care and try to resume life. And I would remind them of their goal. Well, your goal is to get out of here. Your goal is not to make friends with some staff member that you don't like. Your goal is not to have your nose in other people's business or that kind of thing. Remember your major goal and work towards that, even if you have to take a few things that you don't like in the meantime. Don't let those little things get in the way of your common goal. And so I would help them with that. And when the client was cognitively able, I would help them, as I said before, reframe and adjust erroneous beliefs. That's borrowed from good old cognitive behavioral therapy, as you probably know, or we'll find out soon if you don't know. And for some of them that weren't very cognitively able, we would engage in basic behavior modification techniques. For instance, we would provide consistent rewards and or consequences for certain behaviors. Notice I said the word consistent there. And that's also, incidentally, something that parents would have a big struggle with, was being consistent in their responses to their child's behavior, whether it was good or bad. I remember one case in private practice right before I stopped private practice to come to work here. I had a parent come in with the kid, and I said, well, how's the intervention going? We had worked out an intervention that the parent was to do, and she said, well, it just doesn't work. And I said, well, that's interesting. Tell me more about the whole thing and how it's going, why it's going that way, what you're doing, all of that. And it turns out she applied the intervention infrequently and certainly didn't have any consistency. And so what does that do? That sends a mixed message to the kid. And so then when she does try to provide the intervention, the behavior would be even worse from the child or from the kid. So it's all about consistency, folks. I've already talked a little about kids needing structure. And again, remember, oftentimes good effective treatment with adolescents is every bit as much working with the parents to help tweak what they're doing. Okay, so there is some information about disruptive impulse control and conduct disorders. It can be very challenging, but yet also quite rewarding to work with these disorders. And for those of you who already work in group home settings, you'll know what I mean with that. Incidentally, I want to recommend a book to you that I may have recommended before, but it's by Dr. Stanton Samanow, who wrote Inside the Criminal Mind. Dr. Samanow has influenced me greatly in my thinking in terms of psychology and all of that, but he's written several books, and one of the books that he's written is called Before It's Too Late, and it's an excellent book on working with understanding and working with behaviorally disordered kids and their parents. Again, it's Dr. Stanton Samanow, Samenow. He's a clinical psychologist, and the book is called Before It's Too Late. And you can Google him, and he has a website. And probably the cheapest way to get one of those books would be just to order it directly from the website. And he'll even autograph it for you. I don't know about you, but I like for my books to be signed by the people that wrote them, if it's a book that I like and enjoy. All right. Thanks for your time and attention. Bye.